Good afternoon and welcome to the Center for Interdisciplinary Health Workforce Studies Spring Webinar event focusing on the latest trends and research in the nursing workforce. We're pleased to have you joining today's webinar. A few center announcements before we begin. First, we posted RN employment data and aging trends to our website for the first quarter of 2016. Overall, the total employment of registered nurses dipped during the first quarter of 2016 with no apparent surge in retirement. We invite you to visit that to view more. Second, we've recently been awarded funding to organize a small invitational meeting of the country's leading forecasters of registered nurse supply and demand. The meeting will take place mid-July in Big Sky, Montana. The goal of the meeting is to carefully review the data, assumptions, and methods currently being used to forecast supply and demand and find new ways to improve our forecasting abilities. We'll produce a report documenting areas of agreement and consensus and opportunities for improving forecasting. Finally, did you miss last month's webinar presentation discussing the influence of scope of practice laws targeting nurses in 21st century healthcare delivery? That webinar was presented by Michael Richards and is now available as a recording in our video library on our website. Again, for those looking to visit the website, you can find all this information and more at healthworkforcestudies.com. After today's presentation concludes, we'll have 15 to 20 minutes for discussion and questions and answers. Please feel free to type any questions you have in the area designated for your questions on the menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll have it posted to our website. We've posted all the previous webinars to our website as mentioned, so if you missed any of the previous ones, you can find them on our website, as well as many presentation slides for the presentations as they are allowed to be posted. Today, our webinar focuses on research investigating how geographic accessibility of primary care clinicians differs across urban and rural areas and how accessibility differs across states with more or less restrictive scope of practice laws. So now I'd like to take a minute and allow Peter Bierhaus, Center Director, to introduce our speaker, Dr. John Graves. Pete?
Hey, thanks, Christy. Peter Bierhaus here. Greetings from Bozeman, Montana, where we have finally transitioned from spring to summer. The snow is disappearing from many, but not all, of the nearby mountains, and the tourists are arriving each day in increasing numbers. But anyway, it is a great personal pleasure to introduce Dr. John Graves, with whom I've had the opportunity to work with while at Vanderbilt University. So John has an interdisciplinary research program that spans the intersection of health economics and healthcare policy, with a focus on the development, implementation, and evaluation of healthcare reforms at both the state and federal level. Now, John was at Urban Institute years ago, which is a Washington, D.C. think tank, and there John was involved in the preliminary design stages of the landmark 2006 Massachusetts healthcare reforms. This work then led to his collaboration with Jonathan Gruber, who is an economist at MIT, where together they modeled the budgetary impact of the Affordable Care Act for the White House, for industry, for nonprofit groups, and leaders in Congress. Since joining the Vanderbilt faculty in 2011, John has developed a broad research portfolio that now includes large-scale national projects on hospital costs and quality, examining alternative models of primary care to address potential gaps in access under the ACA, and on state-level solutions for the design and targeting of subsidies, tax credits, and the Medicaid expansion under the ACA. Yes, John understands all of that kind of thing. So John is a graduate of the University of the South in Sewanee, Tennessee. He holds a PhD in health policy from Harvard University and is the recipient of fellowships and awards from the Agency for Healthcare Research and Quality, from the National Institute on Aging, the National Bureau of Economic Research, the American Statistical Association, and the National Academy of Social Insurance. I'm really pleased that John is going to give us our webinar today. And John, with that, introduction. It's all yours. You hold the microphone.
Okay. Well, thanks, Pete, for the introduction. And it's great to be here on the phone with everybody to discuss this research. So the first thing I'll say before I jump into this is a what I'm going to be covering over the next 30 minutes or so is covered in depth in a published article that appeared in Medical Care back in January. So a decent amount of the findings that you're going to see here, you can go to the Medical Care website and download the paper. And so if you have any follow-up methodologically or anything like that, feel free to consult that paper and its associated appendices, or just email me. My email address will be shown at the end of the webinar here. So this is work that was collaborative with Pete and with our other co-authors, Pranita Mishra, Bob Dittis, Ravi Parikh, and Jen Perloff. So I think we're all well aware that the primary care system in the United States faces a number of significant headwinds from an aging population, from an increasingly chronically ill populations, and more recently from expansion of insurance to the uninsured under the Affordable Care Act. And all of these trends have kind of intersected to reinvigorate an ongoing debate over the size and scope of projected clinician shortages, in particular as they relate to primary care physicians. This is a very vigorous debate. We're going to have some new evidence on that, which I'm going to show you today, but we're not here to adjudicate whether or not there is a physician shortage, or I should say the size of the physician shortage. Well, what we're going to do today is provide additional evidence, but we're not going to have an answer for that. That wasn't the point of this work. What we're going to really do is focus on a subset of this overall debate over primary care workforce, which I think is a little bit more widely acknowledged, or at least under less debate, which is that the primary care physician workforce is maldistributed, with fewer available in rural areas and more PCPs available in urban areas. Now, despite the fact that there's a vigorous debate ongoing over the size of potential physician shortages, there's really no shortage of policy ideas that people have thrown around for addressing gaps in capacity that might result from that potential shortage of physicians. These could range from financial incentives, such as paying clinicians more, to loan forgiveness programs to incentivize them to relocate into certain types of areas, or to serve certain types of populations. It could also involve expanding training programs. There's been a lot of work recently in alternative care delivery models, the idea being that by pooling practices, constructing medical homes, or implementing telehealth, that you can expand the number of people that a particular clinician can reach and serve through alternative care delivery models. So that could impact how we think about how many people in a population a particular workforce could serve. And finally, one element that we'll touch on today in depth is expanding scope of practice. The idea being that if you can allow non-physician clinicians to work at the top of their practice, that they could serve these additional populations or provide additional levels of care to serve the increasing demand for primary care in the United States. Now, as somebody who doesn't work full-time in the workforce field, what was surprising to me, at least coming into this, for one, is that there were very few reliable estimates on where these policy instruments could be feasibly implemented, or where they might be needed, meaning that there's a local gap in primary care system capacity. So as a methodologist, we started in on this, and I was very struck by the limitations that current methods have, not only driven, well, primarily driven by lack of data. And so one of the big contributions of this work I view as methodological, and I won't get too deep into the weeds of that today, but what's very apparent is that traditional shortage designation methods have historically been exclusively focused on the supply of physicians. And what evidence coming from Pete and his group, among others, have shown is that there's an awful lot of nurse practitioners and physician assistants, among other clinician types, that are working in primary care settings that could potentially provide additional services. Another really striking feature of the kind of current state of affairs in workforce projections is that they tend to rely on historical utilization patterns to project forward to model the number of, for example, physicians needed to meet future population needs or future needs for clinicians. And so in a world in which we are currently dealing with all kinds of changes to the fee-for-service system, whether it's new care delivery models, new payment models, new technologies like telehealth, et cetera, it really begs the question of whether these historical fee-for-service patterns projected into the future can serve as a reliable proxy for that future demand. And then finally, one of the really striking things to me was that the shortage designation thresholds, which of course we have to start somewhere, but they really haven't been updated in very long to reflect all of these new trends. In fact, the 3,500 to 1 and 3,000 to 1 commonly used thresholds are pegged to the 75th percentile of data from 1974 on the population and physicians. And so the contribution of this work that I'm going to show you today is that we're developing new methodologies to provide a very detailed local portrait of the primary care system on the eve of the ACA's major coverage expansions in 2014. So what I'm going to show you is new estimates on the geographic accessibility of various populations to multiple types of primary care clinicians, including physicians, nurse practitioners, and PAs. And then we're going to look at these primary care workforce supply estimates, and we're going to compare that to estimates on the total population and uninsured population. So this would be the uninsured population just before the coverage expansions launched in 2014. And then I'm going to link that to state scope of practice laws as of 2013. So there's really four major takeaways that I really want to put up front from this work, so we don't, get lost in the weeds and get distracted from the main point or the main lessons of our work. So what I'm going to show you is very divergent locational tendencies between physicians and nurse practitioners and even physician assistants, meaning that where nurses locate, at least nurse practitioners providing primary care services, is totally different from where physicians locate. And this is probably already known, but I'm going to show you some new evidence on that. I'm also going to show you that restrictive scope of practice laws are associated with fewer accessible primary care NPs across the United States. But the big caveat to that is that scope of practice is not a silver bullet. The fact that there are more NPs in states that have less restrictive scope of practice laws does not necessarily mean that more NPs are locating in the areas with the most acute needs. And to kind of get our heads around why that might be the case, we're going to point to specialization trends, which are equally as salient for NPs as they are for physicians, particularly in urban areas. What I think our evidence is going to show is that while scope of practice could be used to expand capacity, we need complementary efforts to incentivize careers in primary care. Simply flipping the switch on scope of practice won't by itself incentivize careers in primary care. And so we really need efforts in that area. So in terms of the outline of the next 25 minutes or so, what I'm going to do is show you a really simple example of how we're measuring geographic accessibility to primary care clinicians. I'll then go briefly into the data sources that we're using, the measures that we're using in our study, and then I'll use that to launch into a full set of results. And then I'll conclude the webinar with some discussion points and conclusions, which are really going to draw back to those key takeaways that I just mentioned. Okay. So going into this project, I wanted to answer a very simple question, and that was, what % of the ACA's coverage expansion population lives in a primary care shortage area? So you may recall when the ACA was passed and as we were leading up into the major coverage expansions, there was a whole lot of worrying about whether this expanded insurance was going to overwhelm the primary care system. And going into this project, which was kind of coincident to all of those concerns being thrown about in the media and in the research area, et cetera, I really wanted to get an answer to this question, and there really wasn't a good answer to be found. And so what you see, if you start to dig into that, and I realize that most people on this webinar are well aware of these issues, is that in the United States, our primary way of defining primary care shortage areas is taking some estimate of the population of a given area and dividing it by the number of providers in that area. And historically, as I mentioned earlier, that number of providers was basically a number of physicians. So this polygon that's shown on the graph or on the slide here is for Autauga County, Alabama. So Autauga County was selected because it's the first county listed alphabetically in the United States. So in other words, you don't really have to go very far to figure out where the problems lie in terms of defining primary care shortage areas using this kind of population to provider ratio, which we historically use. For one thing, again, other clinicians such as nurse practitioners, PAs, or other primary care clinicians are left out of the equation here. So to the extent that there's a lot of these type of clinicians in the area, then our estimate of where the shortages are is really kind of not capturing the full picture. So what we do, this is again Autauga County and 2 contiguous counties, is typically at a county level take the ratio of the population to the number of providers. And I'm sure we all know this. In some cases, we'll add in a few more nuances to this. But if you did that for these 3 counties in Alabama, this is what you'd find. You'd find that Autauga County, which is that county in the upper left there, has a population to provider ratio between 2 and 3,000 to 1, which is kind of approaching a primary care shortage. The county adjacent to it has a primary care or a population to provider ratio of over 4,000 to 1, while the other county on here, which contains the capital city of Montgomery, has a population to provider ratio around 1,000. So based on this kind of historical methodology, we get these very sharp edges as we cross county borders, showing that one county on the one hand has a very acute primary care shortage, while right across the way we have a county with much less acute problems. Now, in some cases, what these established methodologies do is allow for some kind of cross-county adjustment. So in other words, if the adjacent county to you is, if the population centroids are within 30 minutes travel time, then that estimate for the ratio can borrow from the number of providers in that adjacent county to try to adjust for the fact that, you know, there aren't walls built around every county in the United States. People can cross county borders to seek care. What was interesting to me, though, as we looked into this, was that if you look at the mean commuting time in the United States based on census data, meaning the travel time that people spend every day going to and from work, in urban areas it's 25 minutes, in rural areas it's 27 minutes, in high-income areas it's 24 minutes, and in low-income areas it's 28 minutes. So across whatever dimension you cut this on, people spend, you know, on average between 25 and 30 minutes a day commuting back and forth to work. So that really raised questions in my mind in terms of, is it really reasonable to put a restriction of 30 minutes travel time on being able to draw upon clinician estimates in adjacent areas to readjust our population to provider ratios to better reflect what the local conditions look like in terms of not only where the clinicians are, but how far people are traveling on a daily basis. So what you see in the county travel data on these 3 sets of counties is that roughly half the population of these 2 adjacent counties to Montgomery travel into what is that county, including Montgomery, which is called Montgomery County, on a daily basis for work. And this kind of insight serves as the basis for a methodological approach for how we're going to redefine population to provider ratios in our study. So what we've done is draw upon what's known as a gravity model. And what it essentially does is use county travel data to readjust population to provider ratios to better estimate what the local workforce distribution looks like in terms of how well geographically accessible that workforce is to the local population. So that's one thing we're going to do, is we're going to incorporate county travel patterns locally observed in census data to re-estimate these population to provider ratios. And the second thing we're going to do is add in non-physician clinicians into our measure, into that denominator. So we're going to include in our measure of primary care clinicians, nurse practitioners providing primary care services, as well as PAs providing primary care services. And so what you see is after you apply our gravity model to these data, it basically evens out those rough edges that you saw earlier when we just did a strict population to provider ratio. So these methods are underlying all of the estimates that you're going to see today. And I just wanted to give you kind of an intuitive grasp of what we're doing and how that compares to usually used methods. Now this chart is a little bit deep in the weeds, but I wanted to provide it just for some of the folks who might be interested in this topic. What I want to highlight is basically how our implied population to provider ratio from the gravity model compares to what we would get from just a standard population to provider ratio. And what you can see, for example, is in the second to last panel here of the results. What it ends up doing is the two lines here are the distribution of the population to provider ratio. So think of this as kind of almost like a histogram of for counties in this example of the second to last panel. These are completely rural counties adjacent to a metro area, and the last panel is showing completely rural counties with the same population but that are not adjacent to a metro area. And what you can see in the red line is what the distribution of strict population to provider ratios would show. And then the black line is what the implied population to provider ratio shows for our measure. And what it basically does is for these areas that are adjacent to a metro area, it's basically modeling the physicians and clinicians in that metro area as being accessible to the folks in the rural county that's adjacent to another county with a major metropolitan area. And so what you end up with is, I think, in my opinion at least, a little bit of a better estimate in terms of you're allowing those folks, you're not restricting those folks from accessing providers in the metro area by simply taking their county population to provider ratio. Okay, so for this study, the level of analysis we could perform this on is the county, and there's going to be some limitations to that I'll get to at the end. The population estimates that we're going to use are Census Bureau estimates on the total population and on the uninsured population in 2013, which again is just prior to the coverage expansions under the ACA. We're also going to incorporate into our gravity model the Census Bureau county travel data, so we're going to be able to observe for every county in the United States the population flows in terms of daily commuting between nearby counties. And then we're going to draw upon workforce estimates from the Area Health Resources file. So in terms of constructing a measure of the total primary care workforce in an area, what we did was follow the ACA's negotiated rulemaking committee to the extent we could with the data that we have. So we're going to include both non-physician and physician clinicians in our measure of total primary care clinicians in an area. And then we're going to create that measure by including medical doctors specialized in family medicine, general practice, general internal medicine, pediatrics, OBGYN, and emergency medicine, with additional estimates on DOs, certified nurse midwives, NPs providing primary care services, and PAs providing primary care services. So for the last two of these measures, in the ARF data, we have an estimate of the total number of NPs and the total number of PAs in a given county. And we had to adjust those to reflect an estimate of how many of those, what proportion of that total in that county is working in primary care versus in a specialty setting. And I will refer you to the paper for how we did that. But we basically we used some additional data to come up with an estimate for every county in the United States of what share of the NPs were actually working in primary care versus in other settings. Our work is also going to categorize states based on their scope of practice. And so for that, we're following the Institute of Medicine and the National Council on State Boards of Nursing recommendations in terms of putting states into three buckets. One bucket, full practice, would mean that that state had no restrictions on scope of practice for NPs, for evaluation, diagnosis, ordering, interpreting diagnostic tests, and prescribing. So that would be reflecting in 2013. Reduced practice states, we're going to categorize as states that reduce the ability, for example, through a collaborative agreement or required collaborative agreement with a physician for one or more of these services. And we're going to categorize restricted practice states as those states that put restrictions on at least one of these services, meaning that they can't do it at all. So in terms of our outcomes, I'm going to show you results for several things. The first set of results, what I'm going to show you is the number of geographically accessible clinicians per 100,000 population by clinician type. So in other words, I'm going to show you how many primary care physicians there were per 100,000 areas by different area types. I'm going to show you how many geographically accessible nurse practitioners in primary care per 100,000 population, and finally the same thing but for PAs. We're then going to do the same thing, but we're going to think about this in terms of not the total population, but the total number of uninsured. So remember that there's a very acute concerns over particularly areas in rural areas being overwhelmed by newly insured people under the ACA. So we wanted to get a handle on how many uninsured people are there per primary care clinician, recognizing that the uninsured don't necessarily start off without some place where they get care. So it's not like this is just totally new patients to an area, but we wanted to put a number on how many uninsured people there would be per primary care clinician in a given area. And then another way we're going to cut the data is in terms of the overall geographic accessibility index. So this is going to be based on the implied population to provider ratio. So we're going to call low capacity counties the top 1/3 of counties that had the highest implied population to provider ratio. That's going to be called a low capacity county. And likewise, there's a typo at the bottom there, should say high capacity. So high capacity counties are going to be the counties with the lowest implied population to provider ratio. And medium capacity are going to be that middle third. Okay, so that's enough of the methods out of the way. Now I'm going to jump into the results. So there's really two things that I want you to take away from this figure here, or really actually three. One, this 89.8, whoops, on the top says that there are 89, almost 90 geographically accessible, nationwide, 90 geographically accessible primary care physicians per 100,000 population nationwide. And then you can see here in the bottom of the figure how that varies by different geographic areas. So at the very top of that is going to be the most urban areas, where we find 92.1 per 100,000 population in terms of physicians. And at the very bottom would be the most rural areas, where it's 69.7. So this is the kind of standard result you've probably seen many times before, showing the maldistribution of primary care clinicians. That is, that they're more accessible in urban areas than they are in rural areas. What's very striking about this is when we look at other primary care clinician types, you see the absolute opposite pattern, particularly for NPs. For NPs, there's overall nationally 13 per 100,000. This is NPs providing primary care services. But NPs are actually more geographically accessible in rural areas, which this 21.8, than they are in urban areas, 11.3. So this is a very striking finding, that we find divergent locational tendencies among primary care clinicians by type. And the last thing I want you to take away from this is the size of the dots. The size of the dots is telling you how many, for that given area type, so most urban to most rural, how many uninsured people there were in 2013 per primary care clinician, showing that in these very rural areas there was a lot of uninsured people, roughly about 200 per primary care clinician in these rural areas, versus in the urban areas where it was more like between 100 and 140. The next plot here is breaking down the population by what % of the population lives in these low accessibility counties, medium accessibility counties, and high accessibility counties, which is the number in blue. So what the top line here is showing you is that 14% of the US population, by our estimates, is living in one of those, basically the top third of counties in terms of their population to provider ratio. So by way of comparison, I think the Kaiser Family Foundation tried to get an estimate on what percentage of the population was in a designated primary care shortage area, and they came up with an estimate, I believe, of about 15%. So we're roughly on the same magnitude in terms of our estimated percent of the population in a low accessibility county, and other estimates of the percentage of the US population that lives in a designated primary care, geographic primary care shortage area. One of the most important things, though, that you can take away from this figure is this set of results in the second panel. What this is showing is by scope of practice categorization, the percentage of the population living in each of these three types of areas. And what's very striking to me in this figure is that roughly equivalent percentage of the population lives in those low accessibility counties in restricted practice states versus full practice states. That is, to the extent that these full practice states may have more NPs in particular working in those states, what it results is more of the population living in a high accessibility county and virtually no change in those low accessibility counties, meaning that to the extent that there are more of them, they don't seem to be locating in areas that may have the most acute needs. And there in the bottom of this, you can see this again by that most urban to most rural categorization, where you see that in urban areas, just 7% are living in a low accessibility of the population, living in a low accessibility county, versus almost half of the population in these very rural counties are classified as low accessibility. Okay, so I'm going to explain this and dig into it in very much more detail than you can see on this very busy slide. But what I want to emphasize here is that what we've done for this set of results is ask, is liberalized scope of practice associated with having more primary care nurse practitioners, physicians, and physician assistants relative to full practice states? And that's what these numbers are showing. So let me dig into this. But first, I want to note that these results are based on a regression model that adjusts for population size, income and poverty, educational status, race, ethnicity, sex, and unemployment rate. So everything is trying to put counties on equal footing in terms of all these measures. I should say that we're not attempting to get a causal estimate here, but we just want to kind of compare counties that are similar on all of these dimensions and ask whether those counties that happen to be in full practice states have more NPs or PAs or even physicians for that matter relative to similar counties in restricted practice states. So what this is just a drill down on some of the results in the previous slide. But what this is showing that is for nurse practitioners. So for nurse practitioners, what we find is there's about an average of 20.26 nurse practitioners per 100,000 population in full practice states. But then if you look and control for those other things, at reduced practice states, that number goes down to 16.15. And in restricted practice states, it goes down a little bit further to 14.88. So what this is showing is that conditional on all those things that we're controlling for, reduced practice states have 4 fewer, or about 20% fewer, nurse practitioners relative to full practice states. These are the same numbers, but for primary care physicians. So in full practice states, we have 78.22 projected primary care physicians per 100,000 population. And in reduced practice states for NPs, it's about the same, it's 80. So there's very few differences in terms of primary care physicians in terms of state categorizations on scope of practice laws. But what we see is a statistically significant and roughly 20 to 30% lower number of nurse practitioners practicing in reduced and restricted practice states relative to full practice states. Okay. This graph is meant to show not only at an absolute level how many primary care clinicians there are in these various urban to rural areas, but we're also going to cut across state scope of practice categorization. So the 3 panels are going to be for full practice states, reduced practice states, and restricted. And within each of those set of states, you can see metro areas that are the most urban all the way to the most rural. So the top line here, this 116.5 on the far right, is showing that in the most urban areas of full practice states, there's 116.5 primary care clinicians per 100,000 population. And recall that primary care clinicians includes physicians and NPs, or non-physicians. So in those areas, there's 116.5 per 100,000 population. And of those, 16.7% are non-physicians and 83% are physicians. Versus if you go down to the most rural areas of full practice states, what you see is there are fewer of them, but almost a third of the primary care workforce in these areas are non-physicians, and 2/3 are physicians. And so now you can go down through the other state categorizations in terms of scope of practice and see, for example, that in restricted practice states, there are 70.3 total clinicians per 100,000 population versus 102.3 up there at the top in the same kind of rural areas, but in full practice states. And in these restricted states, in the most rural areas there on the very bottom, you have 28.9% of the primary care workforce as non-physicians versus 71% as physicians. So what I want to do now is step back and kind of summarize what I've just laid out. What I just showed you is the very divergent patterns in the geographic accessibility of primary care clinicians. So physicians are more likely to be geographically accessible in urban areas as compared to rural areas, but primary care NPs in particular are more geographically accessible in rural areas than they are in urban areas. One really interesting thing that's struck out for me in this project is the following kind of fact that falls out of our results. So if you look at primary care nurse practitioners per 100,000 population, what we find is there's actually more of them in rural areas of restricted practice states than in urban areas of full practice states, which I find is a really interesting result. And it's going to kind of speak to the discussion and conclusions, which I'll get into in a second. So the last point here is showing that despite having more accessible non-physician clinicians, rural areas have the largest number of uninsured per PCC. So despite the fact that non-physicians are more likely to locate there, it's not enough to make up for the fact that there's maybe capacity gaps as the uninsured continue to access care under the coverage expansion. So in terms of discussion, I think it's really important to point out that in anticipation of these workforce challenges, the ACA did a number of things. For one, it called for the development of new programs to grow the physician workforce, and it expanded resources to FQHCs. It expanded loan forgiveness programs and teaching health centers. And this is just a short list of some of the things that it's trying to do. What I think we come away with from this research is that while these efforts will, I think, help alleviate geographic disparities across the United States, it will obviously take many years and perhaps even decades for these efforts to bear fruit. And what I think our results highlight as well is great uncertainty as to whether these efforts will attract enough physicians or non-physicians to areas where they might be most needed. So in terms of what we're contributing with our study, I think we provide very new evidence and context for the debate over the role of scope of practice in expanding primary care system capacity. Now, again, remember that our study design was not intended to provide causal estimates on the effect of scope of practice on geographic accessibility. We're merely describing patterns that we see in the data, comparing states with and without more and less restrictive scope of practice. But what we show in particular is that these restrictions are associated with up to 40% fewer primary care nurse practitioners in some areas. And this would seem to support the case arguing that removing restrictive scope of practice regulations would expand overall capacity of the primary care workforce. And while that's probably true, with the caveats I just mentioned, what we also find in this study, which I think is really important, is that a similar fraction of the population resided in the lowest accessibility areas across all scope of practice environments. So to the extent that these non-physicians are more geographically accessible in these states with less restrictive requirements, they don't appear to be differentially locating in areas that might have the most acute needs. And to understand that, we really have to go back to the fact that well-documented trends towards physician specialization are equally as salient among non-physicians. And so this specialization trend is really acting as a major headwind against efforts to expand primary care system capacity through relaxation of scope of practice alone. So in other words, removing these scope of practice laws may expand the overall capacity of the primary care in the short run without further efforts to incentivize careers in primary care. It's not clear that such efforts will expand capacity in the lowest accessibility urban areas where these specialization trends are more pronounced. So what we conclude with this work is that workforce planning should prioritize the development and implementation of complementary approaches such as payment incentives, telehealth, and innovative team-based care delivery models. So just to conclude, I want to emphasize a few limitations from our work. And really, I think this work is just kind of teeing up what I hope to be additional work using better data and methods. So in this research, we're really only focusing on one thing, which is geographic accessibility. We are not tying our estimates of geographic or how accessible the local primary care workforce is to a definition of adequacy. That is, we're not saying whether a particular area is in shortage because we're not defining what an adequate number of clinicians would be for that area. So combining our geographic accessibility estimates with an adequacy estimate would mean that we'd have to account for differences in demand for care, which is going to vary greatly by local area and population. And so these factors are continuously changing given the new care delivery and payment models that we're seeing, given technological changes, et cetera. So for this work, we've really sidestepped this issue of whether for a particular area the available clinician workforce is adequate. We've really focused more narrowly on how many clinicians are geographically accessible to that area and how does that compare relative to other areas in the United States. Another limitation of our work is that we only had data on commuting patterns. And so effectively what this means is that we're assuming that patients would be as willing to travel, would be willing to travel as far for primary care services as they do for work, or to the same areas even. And so that's an assumption that we had to make given the availability of the travel data that we had access to. And then finally, we use the county as our unit of analysis. So there's all kinds of issues that come up with using counties as a unit of analysis, particularly for really large counties like LA County, which could span hundreds of square miles and cover millions and millions of people, versus other counties, for example, in Kentucky, where they have tons of counties with low numbers of population in each one. And so this is a limitation, an acknowledged limitation of our approach, is that we only had county data. And so you should interpret our estimates with this limitation in mind. So our estimates, we're not providing in this project individual county estimates for this reason. And so in addition to that, the utility of our measures are probably less informative for very large counties. So I will end it there and open it up to questions, but here's my contact information and also an acknowledgement of the initial funder for this work from the Robert Wood Johnson Foundation.
Great. Thank you so much, John. That was an excellent presentation. At this point, we're open to questions from the audience. Please use the questions area of the GoToMeeting toolbar to enter your question versus raising your hand or other ways of trying to ask questions. And we will pose as many as we can get to our presenter. In our usual tradition, I like to let Pete ask the first question. So if Pete has one for John, you can, or any comments on the presentation since you were a co-author, you can go ahead and let you have it.
Hey, thank you, Christy. John, thanks very much for the presentation. It's interesting. I worked with you on this, but I continue to learn new things each time I hear you present. So I appreciate it. Again, I have a couple questions, but let me begin with the first one, and then we'll let others jump in as well. And that is, do you have any hypotheses as to why NP providing primary care and presumably PAs as well are more likely to work in these rural areas versus the urban areas, other than maybe the specialization piece? Is there anything else going on in your mind?
I mean, the first thing I would point to is the specialization, but I'd have to think on that a little bit more. As you know, I'm not an expert in the workforce field other than through this work. So let me kick that to the back of my mind as we answer a few other questions and then circle back to it.
Okay. Well, then let me jump into another quick one. And I'm wondering, and it's a little off topic, but not really. Are you aware in the literature of any new evidence that links the demand to primary care as either increased or stayed the same, or as a consequence of the Medicaid expansions and or the marketplace changes that we've had since 2014? Any new evidence on whether demand is increasing or not?
Well, we have a little bit of work right now on how emergency department use is changing. And what's interesting is at least what we're seeing in the hospitals that we're working with is that we're seeing an increase in the Medicaid expansion states in kind of primary care treatable conditions, kind of urgent but primary care treatable, meaning conditions that you should see a doctor within, say, 24 to 48 hours. And so we're seeing an increase in emergency department use there. And most of the survey evidence has found that people at least self-report better access to primary care. whether that's in a primary care physician office or in a clinic somewhere, or even in an ED, I don't know. I don't think it's drilling down that. But what I think the ED results point to in particular is that, you know, whether because they can't secure an appointment or it's just easier to go to an emergency department because you can get all the labs done and get it just knocked out in a day, there seems to be a little bit more loading onto that type of primary care use as opposed to people beating down the doors of primary care clinics, at least as a general trend. Obviously, it could, you know, that could be happening in isolated areas, but that's based on our work, what I've seen.
Okay, thanks, John.
Great. I've got some questions in here that I'd like to pose. So is there a national database of where nurse practitioners are by zip code that a health system can purchase, like the physician databases? Are you aware of that, Sean or Pete?
Yeah, there's a group at Virginia Tech, I believe, that cleans all the data from the licensure boards, and early on in the project we actually purchased the data for them for NPs, and unfortunately it was just too early in their process. We were missing a lot of areas, so we decided to go with ARF. But I would guess by now that group has pretty good coverage, so they actually get and clean all the licensure, so I presume it's down to the level of the zip code of where the clinician either works or lives, and I can't remember which they collect, if not both. But I think there would be, and I can't remember the name of the organization right now, but they're centered at Virginia Tech.
Okay, great. We have a question about
data. I should add,
okay.
It's the most expensive Excel spreadsheet I've ever bought.
Oh, wow. All right, good to know. What were I think we have a clarifying question. What were the sources of the NP licensure?
Sorry, what were the sources?
Yeah, did you use licensure data in the model?
Well, as I just mentioned, at one point along the way, we do have the licensure data for 2010, I believe, from that organization, and I believe they provide all the inputs into the area health resource file as well. So I'd have to defer to that. I can't remember offhand. But it is from licensure board data largely.
Great. Were you able to note, or were you aware of, or able to take into account any local and institutional limitations on scope of practice that were more restrictive and thus preemptive state level scope of practice laws?
No, unfortunately, you know, we had the state level categorizations. And to the extent that there's data collected on maybe even at the county level, we could probably incorporate that. But all of our data was, in terms of our workforce estimates, was total numbers of clinicians at the county level. So we couldn't differentiate how many of those, for example, work at an institution with a restriction. We're just unable to do that.
Okay, great. Have you found any relationships or similarities among restricted practice states that may have a connection to why there are so many fewer healthcare providers in rural areas, or why those restrictions may exist in the first place?
I don't think I could answer that now. There's a lot more that we could do with the data we've collected. Unfortunately, our grant ran out, so we'll have to deal with that moving forward. But we haven't really looked at that in terms of trying to describe why they might have restrictions.
And I have a question for you. Do you think that the closing that we're seeing of a lot of rural hospitals is contributing to why some of the nurse practitioners or other providers are sort of clustering more towards urban areas, even in free practice states?
We didn't look into closures. I'm not sure that would be, well, that's certainly very salient in the local areas where there are closures. I'm not sure there have been enough. In a given year, there are not that many closures, although they're probably increasingly more so. So we didn't drill down into that So I'm not sure I can answer that one either.
Okay, great. This one might be more towards Pete. Are there enough shortages of primary care in the nation to meet the current and projected supply of NPs and PAs?
Christy, can you repeat that again?
Sorry, Pete. Are there enough shortages of primary care? I think that means providers in the nation to meet the current and projected supply of NPs and PAs.
Okay, I think from what I gather, there appears to be current shortages of primary care physicians, and I think I feel that John has sort of elucidated that these are more likely to be in non-urban areas. I'm still having a little trouble with the question. Sort of, it looped around in a different way than I was expecting. So, the growth of nurse practitioners is very rapid and is much faster than physicians. But I think one of the things that I take home from John's work here is something that even if we have the growth of NPs at a fast rate, it does still appear, regardless of scope of practice, that there's a sizable number of the population, 15%, who reside in areas that are not getting good geographic access. So I'm a little cautious about, thinking about this unless I know where these NPs are likely to go. And if they continue to go in sort of the urban, not continue, but if they do not go in these rural areas, it's not going to contribute to improving the shortages of providers in those areas. We'll still have lack of access to primary care. So we're going to still need to solve that problem. That's my best, Christy, at that. John, I don't know if you got the question a little better than I did, or if you have any thoughts.
Yeah, that's great. Yeah.
Great. Pete, I'll let you ask another one of your questions if you'd like.
Yeah. No, I was thinking, John, on the gravity model, that was pretty wild, and took me several explanations hearing from you before I totally got it. Have you had any comments from people who've read the article that have either raised questions or had comments or ideas for improvement? How's that gone over? Because I think this is actually a much better way of looking at things, but I'm a little prejudiced on that as well.
Yeah, to the extent we've gotten comments, we haven't gotten too much pushback on it, if only because we're moving from a fairly restrictive methodology in terms of strict population to provider ratios, and we're trying to move in the direction of something better, or at least a little bit more realistic in terms of modeling without putting arbitrary geopolitical boundaries on where people can seek care. Now, I would say I think the method has a lot of room for improvement. And I can give you an example of something that really struck out to me in this plot. Is my thing still showing, Christy?
Yes, sorry.
Okay. And can you see my mouse on here? I was wondering that while I was presenting, or am I just...
Yes, I can see your mouse as well.
Oh, great. Okay. So, for example, like if you look at this group here with the 36% and the 21%, these are areas that have exact same population. So this is urban population of 20,000 or more, and likewise here. But this one is adjacent to a metro area, and this one is not adjacent to a metro area. So what you see here is the ones adjacent to the metro area are more likely to be in a quote low accessibility county, meaning that even though we are modeling some of these folks being able to cross county borders and basically go into that metro area to seek care, I don't think we're capturing everything that we could, because we're showing considerably more of those folks in low accessibility counties relative to areas of the exact same size that don't happen to be adjacent to a metro area. So most of the feedback I've gotten has been fairly positive on the approach, and there are certainly similar types of approaches that others have done. We're not the first to use a gravity model to look at primary care, I should be very clear. But I think there's a lot of room for improvement on this in terms of, I don't think that these two numbers are as different as they would appear on this, just because I just think there's a little bit more scope for travel than we're actually capturing in our measure, even though we're trying to do so in a reasonably good way with commuting patterns.
Okay, that's helpful, John. Christy, is there another question?
There is. We have a question. Will research like this be used to change or update the methodology for designating shortage areas?
That's a good question. I don't know. I would certainly be happy to work with anybody that is interested in doing that. I haven't heard anything yet, but we're certainly open to it. Okay,
great. That would be good. I think if we could get it even closer than it already is. Okay, here's another one. Do you think salary disparity between rural and urban areas may contribute to the lower number of primary care providers in rural areas?
I'd have to look. Maybe Pete, you know this offhand, but if there's salary differences within primary care clinicians across urban and rural areas, I just don't know what the magnitude of difference is to comment on that. But certainly between specialty and primary care, that's kind of the gravity that's drawing people towards specialty over other things. So that's definitely the case. But I'm not sure within, say, a given specialty or within primary care, whether there are very large magnitude of differences across areas, above and beyond, just kind of cost of living differences.
On that point, John, a colleague of mine, Karen Donlan, emailed a copy of a report authored by Sue Skillman, Lisa Hager, and Bianca Frogner. And the title of this report is called Incentives for Nurse Practitioners and Registered Nurses to Work in Rural and Safety Net Settings. So there may be some work here that could elucidate some of these questions that we were talking about before. Why are NPs and others in these areas? So thank you, Karen, and we've got some information. Again, it's Incentives for Nurse Practitioners and Registered Nurses to Work in Rural and Safety Net Settings. It's the Center for Health Workforce Studies at the University of Washington. Sue Skillman, Lisa Hager, and Bianca Frogner are the authors, dated November 2015.
Okay, great. Thanks, Pete. We've got one last comment in here I'll squeak in, and then we'll close out. Another modulating factor to contrast the scope of practice restrictions is the credentialing policy of a state's private health insurers. If NPs can't find customer patients who can use their health insurance for NPs, then NPs won't be able to establish sustainable practices. Do you have a quick comment on that comment?
Yeah, that's a great point. We didn't, unfortunately, if there's any data on that, we'd be happy to throw that as another cut of the data, but that's a great point. If people can't match their insurance, even if the providers can practice, from a state level at the top of their practice, if the insurers aren't complying or restricting further, then that's certainly going to contribute to whether or not people are willing to locate there or work there, et cetera. So that's a great point that we did not look at here, but I'd love to.
All right, great. Well, we are right out of time here at the end. I assume we'll be able to make these slides available on the website since the work is already published. We also have the citation and information and contact information for John here if you have more questions. Otherwise, this concludes our webinar series for the spring. We'll be taking a break for the summer, but we'll be back in August through December with our next webinar series, and we thank you very much for attending, and thank you very much, John, for your presentation today.
No problem.